before you do. Oh, it's broadcasting.
Welcome, everyone. I see people coming in. Thank you. So just please give us a couple of minutes before we get started. We're expecting a little over 200 participants, so we'll wait until we're a little bit closer to that. Right now, we're about 80 participants logged in. Welcome, everyone. Please give us a few minutes before we get started. We're expecting a little over 200 participants, so we're waiting for about 100 more folks to log in. Right now, we're at 103.
Come here, couple.
Thank you so much. So many folks are still logging in. We're going to give it about another minute before we get started. We're expecting at least about 250 guests. So just give us about another minute before we get started. All right, so we're going to get started. We're still expecting maybe about 70 more people to log in, but due to our time restraints and we have so much information to go over today, so I wanted to get started. Good afternoon, and thank you for attending our Health Equity, What COVID-19 Highlights About Health Disparities webinar. We are excited to have such an engaged community. So on behalf of our CEO, President Kathleen Cannon, Chief Community Impact Officer Maria Hernandez, and our entire senior leadership team, thank you for joining us today. So for United Way newbies, our work is primarily focused on 3 pillars: education, health, and financial stability. Today's webinar, however, will primarily focus on health, but we know all 3 are intertwined. Our health equity team consists of our senior health director, Janine. She's responsible for managing over $3 million of health dollars, inclusive of behavioral health. I, Elkin Alfred, currently manage our county's crisis intervention team for all law enforcement, and I serve as our internal diversity, equity, and inclusion champion. Aisha is our lead trainer. She's tasked with coordinating mental health first aid and community training. So on behalf of our entire team, again, thank you so much for your participation today. So a few housekeeping items. Videos on for all panelists, off for attendees. We ask that if you have any questions, please use the Q&A box to submit your questions. Webinar is being recorded and will be shared via email within 72 hours. Certificates will be emailed to participants for submission to their accredited bodies in 1 week. So this is specifically for licensed clinical social workers, licensed mental health counselors, and licensed family marriage therapists. We want you to also carry this conversation on all social media platforms. So if you have access to Instagram, Twitter, Facebook, we're encouraging you to use the hashtag #HealthForAll and Live United Broward. So our goals for today is to shine a spotlight on how health disparities impact Black and Latinx communities, to understand how businesses, healthcare providers, government, nonprofits, policymakers, and philanthropy can shift practices to address health disparities. And the last thing is for us to all imagine what an equitable South Florida looks like. So important issues to consider. So due to the limited time today, I wanted to just bring these things to your attention. We won't have the time to cover them, but they are important items for all of us to consider. The need for a network of coalition to support on equity-related issues to ensure community consistency, business engagement and community solutions and how to be built on D&I practices, and then obviously for us, the need for us to expand the work that we're doing on mental health and a trauma-informed care through an equity lens. So our esteemed panelists today, the first panelist we'll have speaking today is Dr. Shanaz Fatteh. She is the Director Division of Asthma, Allergy, and Immunology Clinic and Associate Clinical Professor, Department of Internal Medicine at Nova Southeastern University, Dr. Kiran C. Patel College of Osteopathic Medicine. Dr. Fatteh is an allergy immunology specialist with the Asthma Allergy Care Center of Florida. She earned her undergraduate degree from Emory University and received her medical degree from the College of Georgia. Dr. Fatteh completed her internship and residency at Jackson Memorial Hospital and University of Miami and completed all her allergy and immunology fellowship at New York Hospital. And she is the current president of the American Associates of Allergists and Immunologists from India and the president of Broward County Medical Association. Following her will be Dr. Shanaz Fatteh, who's the Director, Division of Asthma. The next speaker would be Dr. Haffizulla. She is currently the Associate Dean at Nova Southeastern University and is currently the lead principal investigator for the Caribbean Diaspora Project. She also is a leader in ensuring gender parity in medicine. So I'm super excited to have her on board as well.
Thank
Leigh
you.
Ann Bucanan is the founding executive director of Venture Cafe Miami. Under her leadership, VCM's innovation programming has attracted over 45,000 innovators, resulting in content partnerships with 1,000 plus organizations and 1,500 free educational sessions. She's an author, facilitator, and frequent speaker on strategies for inclusive innovation ecosystems and entrepreneurship-led economic development and social justice innovation. And then we will have our last speaker of the day will be Representative Shervin Jones, who's a former educator and is currently helping to lead this conversation on health equity as it relates to policy. Dr. Fatteh, you're up.
Thank you, and thank you so much for inviting me to speak. It's a pleasure to speak to all of you today. I think we've come to a new understanding of how we meet and greet everybody today. So this is another Zoom conference, and I hope all of you are doing well. Today, my task is to really talk a bit about health disparities, and disparities in healthcare are of great concern to all of us. And a lot of this leads to what we think of as unconscious bias or implicit bias. So how we interact with people, how we treat people, how we take care of them can often be affected. And so that can affect our treatment plans and how we have dialogue with our patients. So we'll address some of this and look at it more specifically to Broward. So Broward County, I think one of the questions we've had last time I spoke for United Way, we had 55 cases of COVID-19 in our county. As you can see that this has rapidly changed over the past several weeks. Broward County certainly has reached its peak and is starting to get a flattening of the curve. We know that if we have a flattening of the curve, then we are starting to get decreased infection rates in our community. So let's look at the coronavirus summary for Broward County, and this is about 2 days ago. So 2 days ago, we had Florida residents, total cases were affected were about 4,847. As of this morning, that's gone up to 4,953. Our gender for Florida residents has been slightly more with men than women, and the average age range has been 0 to 102. But pay attention to that median age is 50. So that lets us know that many of us thought that initially that this was really going to affect more people who are over the age of 60, right? And so the median age in the state of Florida is 50. So that means that we've got younger people also affected. And so we'll talk a little bit when we get to disparities about what that could be in terms of some of the implications of who these folks might be that are more affected. Next slide, please. So let's look at the COVID-19 racial disparities. This is kind of a busy slide, has a lot of information in it, but I do think it's very important. If you look at the hospitalization rate for our county, 49% have been white patients, and we have a total of 33% that were hospitalized that were African American. In terms of deaths, we have had 48% of white patients have died from this disease, and 36% of Black patients. And you can look at the other breakdown in terms of Hispanic patients. So there have been quite a few Hispanic patients also affected, and also about 9% of Hispanic patients that have passed away either with a Hispanic or non-Hispanic ethnicity. So in the total number of patients who have died in Florida and Broward County has been about 4% of all cases. And if you look at 4%, that's higher than we would expect for influenza infections, right? So influenza, COVID-19 death rates have been higher than what we've seen in the past with flu, traditional flu that most of us are familiar with. About 19% of people who have been hospitalized with COVID-19. Next slide, please. So this is the CDC's report on racial disparities. And unfortunately, racial disparities, as I mentioned, does impact healthcare and how we treat with patients. So if you look at 580 patients that they looked at that were hospitalized with lab-confirmed COVID-19, 45% were white compared to 55% of individuals in the surrounding community. However, those that were hospitalized, 33% were Black compared to 18% of the community, 8% were Hispanic. And so what this data really shows is that there's an overrepresentation of Blacks among hospitalized patients. If we look at a city that's been really hit hard with COVID-19 that we see all the time on the news, looking at their data, which has been studied, New York City, particularly Manhattan, Black and African American patients had a death rate of 92.3 deaths per 100,000 in the population. And compare that to Hispanic, which was very high as well, 74.3, and white at 45.2, and Asians at 34.5. So a very disproportionate rate. Recently, many of us in the past 2 days have also been looking in the news and seeing the reports in Virginia. So counties that have a predominant African American population as well, such as in Richmond, Virginia, have seen that they had 312 COVID-19 cases just in the past week, 60 hospitalizations, of which 14 persons passed away. And when you break the racial ethnicity down, 13 of the 14 were African American. So there is a disproportionate overrepresentation of African Americans passing away and being affected by COVID-19. Next slide, please. So what are the causes of this disparity? So we can look at these factors and delve a little bit deeper into each one of these. Living conditions. So when you look at living conditions, people may not be living in the most environmentally safe housing, and that can really affect how our housing is made and the physical footprint of the housing too. How much space do you have within your housing? There's lack of supplies and access to care. So when you think of lack of supplies, do we have green grocers? Do we have access to physicians and healthcare service right around the corner? Do we have different food sources? These homes are often multi-generational. That means we could have first generation, second generation, third generation, even fourth generation persons living in the same household. So you could have young children as well as grandma and grandpa. So trying to socially distance ourselves, which is very important in tackling COVID-19, can be quite difficult when you have many people living in the same household. There seems to be an overrepresentation as well in patients in jails, detention centers, prisons, and all this can lead to people having to live very close and proximate to each other. Again, social distancing can be quite a challenge, and having to eat together in terms of shared food services like cafeterias, where it's difficult to have social distancing, also affects persons. Work circumstances certainly have an impact. So we know that nearly 25% of Black or African American workers are employed in the service industry. So service industry, we think of this as part of the essential workers as well, and they have 25% of the jobs, whereas 16% of non-Hispanic whites in comparison. So Hispanic workers, though, comprise 55% of agricultural workers. And we think of our community, there's a lot of agriculture here as well. But you may think of these folks as being spread out on a field, but they go in cars and trucks together. So again, often transportation is not available to them. There's not a way for them to distance and keep themselves safe. Black and African American workers are 30% of our licensed practical and licensed vocational nurses. They also comprise a greater proportion of our home health aides and CNAs. And so again, they are encountering people more frequently that may be at higher risk. And there's lack of paid sick leave and access to childcare. All of this means that we have to depend on people to be able to take care of older patients in nursing homes, ACLFs. And so these are all more persons that are Black and African American. So they are at higher risk when they're looking at older population. Next slide, please. So what's Broward County census mix? So this was from the US Census Bureau. Our racial mix and ethnicity is white at about 63.2%, Black at 30.1%, and Hispanic at 30.4%. Some people identify with more than one, so that's why the total doesn't come out to 100%. Health insurance coverage. Health insurance, health care, so much depends on having health insurance. If we don't have health insurance, a lot of people will not seek treatment. They're worried about the cost of coming to a hospital, to an emergency room, or even going to their clinician around the corner. So this can be quite important in being able to take care of yourself. So in Broward County, persons without health insurance who are less than 65 years of age is about 16.8% of our population, and persons in poverty are about 12.6%. So if we look at the US in 18 to 65 years of age, Hispanics and African Americans lose health care insurance at higher rates than any other races. And that really can impact whether we have a decision to be able to go seek care for ourselves. And so this makes an important decision if somebody is young and has a health issue, or even if they're older. So does implicit bias by healthcare providers affect patients? So implicit bias is where we have preformed concepts or ideas about how we care for patients. And this can work both ways. It can work from the patient towards the clinician, or the clinician towards the patient. And this is an area that I really feel needs far more investigation and research, because we know that this is occurring and we need to understand it better and put some more goals to improve this. So the CDC has shown, and United Way and lots of other organizations have shown that many providers hold some level of implicit bias towards patient groups. And most studies that examine these interactions between Black and non-Black providers. And so this can lead to poor interaction if you don't listen to what the patient has to say, if you're not able to communicate, if you are not using language and words that are understood by the party you're taking care of. That can affect how you take care of the patient. It can lead to the patient then leaving you with confusion about what the treatment plan is. What are they supposed to do? What did the physician tell them? So these are really important. When you look at data that has come through for how physicians treat African Americans with pain, a lot of the research clearly shows that if you look at a white person versus an African American person in the emergency room presenting with the same level of pain, that there is bias in thinking that the African American patient can tolerate the pain better. So these experiences with discrimination that can occur with people over time can also make them feel that, can I really trust who the provider is? Is the provider going to listen to me? So these are some examples of implicit bias. Next slide, please. So understanding implicit bias can really help us improve our interaction and care with our patients. There's several groups that are affected, of course, patients with mental health disabilities, and patients who are older, patients with any type of physical disability as well. And these are areas that we need to better address for this pandemic. In Florida, we have a large elderly population, and addressing their needs is very important. You know, mobility can be a real problem for these patients, just being able to get around with walkers and wheelchairs, having support to have people come and help them, getting meals. You know, we have a lot of people who are affluent. They can easily call, order meals, order food, order services to come to their home. This is not always possible for a lot of people, including our older patients as well. And understanding the functional status of these patients from vision, hearing impairment is also important. Most of our patients who are older, as well as many different groups, also have chronic medical conditions. So they also take a lot of medications. And so being able to have the care to deliver this is important. And while we think about these biases, the most important thing that we need to think is how to improve that patient-provider relationship so that we can help eliminate healthcare disabilities and disparities. So I also want to share with you a project that the Broward County Medical Association is really proud of. And we've helped create a medical reserve corps. And so this is a series of persons throughout our community have participated. It's approved through the United States Department of Health and Human Services. We're in partnership with both the Broward Department of Health as well as the Florida Department of Health. And the MRC is established to help preparedness and response to our Broward County needs. And this includes this type of pandemic. It certainly also includes times at hurricane and other crises that our community might experience. Our goal is to be able to have as many volunteers as possible to credential them. We've recruited active and retired physicians, nurses, respiratory therapists, pharmacists, and a whole host of other providers that are essential in being able to give us support in our community if we have a national incident. And we are, of course, looking for more community volunteers. So if you're interested, I've put the website down at the bottom. There is a registration process and a credentialing process. So we are looking forward to having more community volunteers. And I thank you for taking the time today to let me speak to you, and I'll be happy to answer questions at the end.
Thank you so much, Dr. Fatteh. Next up, we have Dr. Haffizulla with Nova Southeastern University's MD program.
Thank you so much, Elkin, and thank you to all of my fellow panelists. Elkin, thank you for being such a wonderful organizer. And of course, to our participants on the call today, it's an important part of our role to really reach out to our community members. Elkin, in the beginning, I appreciate you promoting me to an associate dean, but I'm assistant dean for community and global health. And I serve as a principal investigator for our Caribbean Diaspora Health and Nutrition Outreach Project. And that is the focus of my discussion today. I'm going to talk about this project in the context of having the focus and the ability to eliminate health disparities and to promote health equity. Next slide. I'm going to share with you a sample of some of the information flyers that were generated from our research. Now, this particular project really highlights the importance of community-based participatory research. And this cannot be done alone. This has to be done with a group of community stakeholders who are also invested in this mission to eliminate health disparities. You notice our education materials are not what you normally see. A lot of this reflects the cultural, visual, linguistic, and aesthetic preferences of our Caribbean population. And I'm very proud of the work that was done here. And again, this was done in collaboration with many community stakeholders. This work started off in the Nutrition and Fitness Task Force, the Broward County Department of Health, and quickly took life, with the Broward Regional Health Planning Council and all of the community partners that you see there. The reason why this project is important and why it took life in such a fashion and continues on in this manner is if we look at our Caribbean community, particularly here in South Florida, we'll realize just how diverse we are. Now, we just saw some of the numbers on COVID-19, but looking at the race and ethnicity categories, you really don't have that disaggregated data set to show you where our people are from. Is an immigrant, what is their country of origin? Florida happens to be the #1 state with Caribbean immigrants. And more than 90% of our Caribbean immigrants come from 5 countries. And that was the focus of our research: Cuba, Dominican Republic, Jamaica, Haiti, and my home country, Trinidad and Tobago. And actually, more than 75% of all of our Caribbean immigrants in Florida live right here in our Tri-County area. All the more reason to add importance to these kinds of initiatives. We also know that based on community health needs assessment data, that the leading causes of death for this population include heart disease, cancer, stroke, diabetes, all impacted by diet and exercise. In fact, if you look at data from the July 2015 health needs assessment, 2 in 3 Broward residents, that's over 66%, are overweight, and another over 24% are obese. And there was just a lack of effective, culturally appropriate education materials that focused on prevention. So this program and project and research focused on capturing the preferences of our Caribbean community and then initiating sequences of interventions that aligned well with what we heard from those focus groups. Next slide. So this was really the first research-driven educational outreach program. It's really culturally appropriate for our Caribbean diaspora. And we used the Go Slow Whoa or GSW format that many of you might have seen in our community before. I know that the Health Planning Council, Broward Regional Health Planning Council, had a platform. They had education materials created for the general community. And they were gracious enough to let us use these materials to tailor a Caribbean-focused intervention. And this Go Slow Whoa program actually comes from the CATCH program, which is a coordinated approach to child's health. This program has been used for many years. It's an evidence-based platform that literally uses lights to choose the right options. So go or green is more often, less or slow is yellow, and if you want to choose a food rarely, that's the wool or red. And this is based on the content of nutrients, sodium, fat, and sugar. We also included some active living components in our research as well. The research was divided into qualitative and quantitative arms. The focus group side, where we captured the preferences of our Caribbean community, occurred on the qualitative arm. And that is where we're able to dive deeply, to look at content, to look at organization of the materials, to look at the way the materials were presented, to see if there was any cultural relevance at all, or what resonated with our participants. We also did this for the exercise components, and we were able to make some drastic changes based on some of the themes that were generated. On the quantitative arm, we actually looked at social determinants of health, as you just heard described in Dr. Fatteh's talk. And from that, we were able to tease out areas that we'd like to have further study. And beyond that, once we had the focus groups, we were able to identify places that were frequented by members of our community. And these places that were identified now serve as areas that we can disseminate our newly created materials, and also serves as venues where we can have educational intervention programs and other health equity and health disparity related work. These intercept surveys I will present to you a few slides from now. But let's go back to that slide before, Elkin. You just see a flyer that shows the color-coded fruits and vegetables. Yes, right there. So that again is just another highlight to show you how the content, the color scheme, the way the information is presented, the organization of that material itself, all of this again came from that qualitative data. Next slide. These are some more of those flyers that were disseminated to many of the places identified by our Caribbean focus group participants. And at 92% and 82% respectively, there was an overwhelming majority of our intercept survey results indicated that our Caribbean community felt that these were helpful in making positive food and beverage choices. So we kind of did this from the beginning with creating the materials, after they were created, and of course vetted by our grant partners and nutrition experts on there to ensure that we had evidence-based materials. We actually rolled out the intervention into areas that were identified by our focus group participants, and then we came back with this particular data. So this is reassuring as we continue to build now, not just into the Broward County area, but now into the full Tri-County area. Next slide. This is another set of flyers that shows, again, if you look closely at the content in here, if you're able to zoom in a little bit more, you'll notice that, again, this is not normally what you would see in some of the health education materials that are geared towards the American population. This, again, is very much Caribbean focused and data driven. Our community-based participatory research model is truly what allowed us to generate this information. And that allowed us to build trust, not just with our community members, but to also leverage the strengths of our community stakeholders and the grant partners who are part of this project. This allowed us to really have a prevention focus, a prevention education done in a manner that will resonate and be embraced by our Caribbean community. Next slide. These are some of the social determinants of health that we looked at, and we used a modified PREPARE survey. PREPARE is the protocol for responding to and assessing patients' risks, assets, and experiences. And this is used by community health centers and actually is embedded in many electronic health records. So we looked at age, race, gender, we looked at employment, financial stress, food security, transportation. Overarchingly, we were able to find some differences in different areas. Now, the average age of our participants was about 43.1. About 39% of our participants were African American or identified as such. And then everyone else in our focus groups identified as a mixture of all different types of races. We also gave a category for them to write in how they identified, because that was important as well. Many times you'll find that the data capturing that's done, as I mentioned before, really does not disaggregate the data in such a fashion that you truly see the complexity of the community that you're serving, the true heterogeneity, the complex richness of the community that we're serving. Many of those details from that background and culture plays a role in the health status of the patient. So all of the details generated from this data really help to give us a dashboard for further study and for further change. We found that 37%, for example, of our participants were stressed. And while most patients actually held private insurance, we felt that employment was actually statistically significant based on the country of origin. We actually found more of our participants from Haiti and Trinidad and Tobago were unemployed. If you looked at food security, while most people were able to get food, there was still a portion who could not access food at all. As far as healthcare access, most patients receive their health information primarily from their clinicians. And while most patients did not seem to face a barrier, at least 50%, the other 50% cited cost as a major barrier. Next slide. If you want to dive a little bit deeper into some of the information I'm presenting, because I know we are a little bit short on time, I encourage you to review our research article we got published in the Annals of Global Health this year. And this data, again, sets the dashboard for us to really have an academic, data-driven approach to eliminating health disparities. But again, working in partnership is the only way we will have that happen, and engaging and empowering our community members to become part of not just the process of planning these research protocols and implementing strategies, but to also have their buy-in and to ensure that they are also, they're the priority essentially in this particular process. And we want to ensure that that message is completely loud and clear. Next. Now, since we've finished that first phase of the project and rolled out some of the education materials widely into the community, we've just received grant funding to expand into the Tri-County area. With this expansion, we are now taking the social determinants of health to an even more comprehensive level, really expanding the depth and breadth of the variables that we're looking at. And this will really give us an idea of some of the obstacles, the barriers, where we will need to align resources and where policy changes will be needed. I'm also taking a good look with our team on health status. We're looking at healthcare access again on a greater level, barriers in particular to healthcare access. We're looking at comorbid illnesses, the rates of diabetes, for example, or prediabetes. We're looking at obesity. Personal and family cancer risk is also included in this. Diabetes rates itself is also tied to the chronic management of that disease and how well any one of our community members who qualifies for the study, how they feel they're treated in the course of management of that chronic disease. We've also amended our research to include questions related to COVID-19, so we will know exactly who was tested, who was not tested, if they were diagnosed, and any obstacles that they faced during the course of this COVID-19 pandemic. That is valuable data that can again supplement some of the information that we're seeing on the state level and will really help us to hone in on some of the issues that are pertinent to our county. We are leveraging trusted relationships and we're community capacity building. That is the only way we're able to achieve what we do. So we welcome you and encourage you to join on board with us and help us to have that expansive footprint and to harness some of the connections that you do have, the trusted relationships that you do have, so we can get the data that we need to get in order for us to proceed. So we have all the complementary materials for this particular research available online on that link that's provided at the top here. We do have a text to give campaign to continue funding for this important project and to help, of course, ensure that we look at the depth and breadth of health disparities and ensure that we're working to build a diverse clinical workforce as well to meet the needs of the community here. Feel free to reach out to me at any point in time. I'm looking forward to taking questions at the end. Thank you so very much.
Thank you so much, Dr. Haffizulla. Next up, we have Leigh Ann Bucanan.
Hi, everybody. Thank you so much for having me here today. I'm really excited to chat for a couple minutes. What I was asked to focus on is really to explore how nonprofits can use this opportunity, thinking about reframing the current pandemic and resulting economic impact, to really think about how we can address disparities that can lead to innovation. So I lead an organization called Venture Cafe, as you mentioned in the outset, that really focuses on this idea of building an ecosystem around innovation and entrepreneurship. And so I'm really excited to take the opportunity to look at the intersection of this as it relates to health disparities. So if you can go to the next slide, we can kick it off. A little bit about Venture Cafe. In the last 3.5 years, we've seen about 50,000 people come through the programming that we host on a 1 day per week basis. And that's resulted in about 1,000 partnerships. And over the last 8 weeks, we've had to pivot. completely pivot on how we serve entrepreneurs and small business owners, particularly looking at those that are often overlooked and underestimated. And in the last 8 weeks, we've still averaged about 200 folks participating every single Thursday in our weekly gathering. Last night, we had about 250 actually sign in, and an additional 300 participate by Facebook Live. And so I just want to share some of the steps that we took and that we encourage other nonprofits and organizations to take in terms of beginning to serve underrepresented and underserved populations more innovatively and more responsively. And so there's about 5 particular steps that I'll walk through very briefly in the next couple minutes that you can use and adopt in your own practice of thinking about innovation and inclusivity through ecosystem building. So first, diagnosing the problem. Second, identifying the system, identifying the solution, leading with ideas, and filling the gaps. Next slide, please. In terms of the problem, when we look at the impact right now on kind of small business, some of the stats that I thought were particularly striking is that 90% of minority and women-owned business owners were left behind out of the PPP and CARES Act incentives. And that was not the intention, but that was actually the problem that highlighted significant disparities, particularly where Black and Brown individuals will get the short end of the stick. Next slide, please. And when you look at what that really is looking at is prior to the COVID-19 epidemic, we actually saw that minority and women-owned businesses yielded about 50 to 90% less sales on average than their majority counterparts. And if you look at the next slide, you'll also see that the survival rate of these businesses before were pretty bad. So you see a 50% survival rate after 5 years and 20% survival rate after 1 year. And so when we think about diagnosing the problem, that really speaks to the underlying issue is just real access to opportunities for entrepreneurs of color and low to moderate income folks that are leading and founding small businesses to really be able to see the dream of individual economic mobility. Next slide, please. When you look at the CDC's system for identifying what are those social determinants of health, you have education, economic stability, neighborhood, health and healthcare, as well as kind of those societal community factors. But the one that I want to focus in on is thinking about economic stability. And sometimes we don't see the we often have a disconnect between thinking about health and survivorship and economic stability, but those two go hand in hand in terms of really identifying the system that is interplaying when you see these health disparities. Next slide, please. Looking a little bit deeper at what some of the data shows, and this data is from the racial wealth divide study that was led by Prosperity Now. This is more focused on Miami because that's where we're based, but I'm sure that the data is very similar as it relates to the Tri-County area. You see about a 74% rate of liquid asset poverty. And then when you do a specific breakdown by race, you see that there's striking disparities, particularly for Black and Latino individuals and households in terms of liquid asset poverty, about 79% for Blacks and about 74% for Latinos. And then additionally, you see significant disparities as it relates to zero net worth households. And when we think about social determinants of health, one of the most overlooked determinants is the idea that poverty, specifically cyclical poverty, is what helps to contribute to some significant health disparities because it spirals then on. Next slide, please. So the solution that I would offer and that I like to think about is in terms of framing this as an ecosystem. Kauffman Foundation talks about ecosystems around entrepreneurship and innovation as those that thrive when people and resources are connected and working together to develop new approaches and solutions for serving. Next slide, please. And when we look at that a little bit differently, I think it's Jack Sim that is known for saying that entrepreneurship is the one thing that has lifted billions of people around the world out of poverty. I wish this webinar were more interactive, but if it were, I would ask you to drop in the chat feature, you know, whether or not you know someone in your immediate family, in your extended family that had a side hustle, someone in your family that had something they did on the side to bring in a little bit of extra money, or owned a small business. If you look at the business ownership rate in South Florida, particularly in immigrant heavy communities like what we see, that has high rates of entrepreneurship and business ownership. And entrepreneurship is one of those tools that allows for individuals to be lifted out of poverty, and it allows for there to be a greater sense of self-determination in creating opportunities. And so some of the solutions that I suggest nonprofits look at adopting is something similar to what Venture Cafe has done in terms of rethinking how you serve particular communities, particularly looking at communities of color, and particularly thinking about low to moderate income entrepreneurs and business owners. Next slide, please. And so kind of there's two solutions that I would suggest we adapt in terms of framework or a model that nonprofits can actually use in becoming more innovative in the way that they serve their constituents, be it health-related nonprofits, be it nonprofits that are serving small business owners, be it nonprofits that are thinking about entrepreneurship, or organizations much like the United Way or Venture Cafe that are more umbrella, looking at how they connect different parts of the puzzle. And so this acronym IDEAS is a very simple solution. So leading with ideas, what does that look like? So IDEAS is actually an acronym that stands for inclusion, diversity, equity, access, and storytelling. I'm a very practical person, and I really like to have solutions and frameworks that I can just immediately adopt in terms of making a difference. And so ideas, starting with inclusion, first, revisit who you serve. Who you serve is going to change because the world has changed. And so asking, you know, at Venture Cafe, we ask, is innovation for everyone? And who is that everyone? And how do we create a sense of belonging? And so for nonprofits or even health professionals, rethinking who you serve is going to be important because the people that you serve may change given the changing nature of what's happened with COVID-19. Secondly, diversity. Diversify the resources and partnerships that you have as an organization. Rethinking about how resources are being distributed and diversifying the number of organizations that you're currently collaborating with, and thinking about the types of services that you're providing, because they may need to change. For example, Venture Cafe, when we think about how we serve entrepreneurs, everything we did was in person. And in less than 7 days, we had to shift to being completely online. And since then, we still see an average of 200 folks a week, and we've been able to partner with even more organizations, including those globally and across the country. An example that I would give is the Florida International University, the Downtown Development Authority, and the Greater Convention and Miami Visitors Bureau were able to think about helping to support food entrepreneurs, particularly when we look at Black and Brown communities. A lot of entrepreneurship is entrepreneurship by necessity, and beginning to serve a lot of food entrepreneurs with the different resources through a collaborative model. E, in terms of equity, is thinking about third, what obstacles prevent or discourage participation? You know, the earlier panelists discussed the obstacles or the impediments to being able to access health resources and to be able to access services. As organizations, we need to look at what obstacles prevent or discourage participation. They could be transportation, they could be technology, they could be awareness. If you're thinking about social media as the only means of communicating because of social distancing, a lot of communities are not having access to technology in the way that maybe the rest of us have the privilege of doing so in terms of a webinar. And then looking at access, that the fourth piece is access. whether or not there's a cleared roadmap for access to the resources you're providing, as well as upward mobility. In terms of entrepreneurship and innovation, we encourage organizations to look at whether or not you're going to see positive outcomes and whether or not there are opportunities to measure the data about the output of the resources that you're providing and the outcomes for your primary constituency. For example, you know, right now, I just looked at the unemployment rates, particularly in Florida and across the country. 1 in 5 Americans are now unemployed or are seeking unemployment benefits. That is both devastating to our economy, but it also presents an opportunity to rethink how you serve individuals, because now people are going to be self-employed by necessity. And so how can we maximize their chances of success in this new normal of entrepreneurship and self-employment? And then the last thing is thinking about storytelling. The data and disparities that the other fellow panelists have discussed prior to my opportunity to share some of these strategies and insights was telling a very bleak story as it relates to particular populations. And one of the things that I'm always wary and conscious of is how we as organizations contribute to a narrative of a single story. Looking at the way that we're communicating to different populations, thinking about the people that become the poster child for the resources that we're providing helps to create more of a diverse and authentic view of the story or the narrative of what's happening. And so I think one of my favorite quotes on this point is by Chimamanda Ngozi Adichie that says, "A single story creates stereotypes." And the problem with stereotypes is not that they are untrue, but that they are incomplete. They make one story the only story of a particular moment in time, a particular resource that we're providing as organizations, and of the opportunity that can exist under coronavirus or COVID-19 to really hone in on the reality of some of these health disparities. I think the last thing that I would say is the disparities that we're talking about, and the world that I sit in is looking about entrepreneurship and innovation and how nonprofits can better serve, is that they limit access to resources and capital for individuals that need them the most. And we're not just talking about financial capital, you know, social capital and capacity building and political and financial capital are all types of capital that are necessary for not only organizations that are looking to serve better, but also for entrepreneurs, small business owners, and those that are getting the short end of the stick in terms of the economic impact of COVID-19. And I think one last thing that I'll leave you with, understanding that we are limited on time and want to open it up for more discussion, is that taking a wraparound approach to putting the client or the individuals that you serve at the center allows us to become more flexible in creating individualized outcomes. And that actually takes more time.
You're muted, Leigh Ann. Leigh Ann, you're muted for some reason.
I think that someone just became the co-host and that muted me. So the last thing I was saying is we can increase the impact of the work that we're doing by creating individualized outcomes and wrapping our services around those that we're serving. And the last slide is just a quick slide as an example. If you can move to the next slide, it's an example of what that looks like in action relative to Venture Cafe's work in Overtown, working with low to moderate Black entrepreneurs in that community. And I think Representative Jones has joined us. So I would be happy to pass the buck over to my dear friend.
Thank you so much, Leigh Ann. And next up, we have Representative Jones. We can't hear you, Representative Jones.
Hello, my name is Jessica. I'm his legislative assistant. And let's see if I can figure out, one moment. I'm gonna do start video. And yes, okay. My name is Jessica, and I'm his legislative assistant. Representative Jones, his full-time position working for the Florida Reading Corps, they had an emergency budget meeting, and unfortunately he has to furlough several employees, Sign of the Times. So he's still in discussion regarding that, and I have the pleasure to follow up on all this great discussion and talk a little bit about health equity. Do you want to go to the next slide? Okay, so the Florida imbalance. And I wanted to start off this discussion with the knowledge that has already preceded this. And we know that Black people are contracting COVID and dying from COVID at a much worse rate that's not proportional. And residents of majority Black counties have 3 times the rate of infection and almost 6 times the rate of death as residents of majority white counties. And there are many reasons for this that we've already gone through, that there's not the opportunity for adequate social distancing when you're in frontline work and you're doing essential work. And another contributor to this is that the CARES Act provides for COVID-19 testing for free to the patient, testing and treatment free to the patient, but that doesn't help if the COVID-19 test comes back negative and you're still sick and under or uninsured. So we're seeing reports of patients hit with bills for thousands of dollars because they had influenza instead of COVID. And so there's a major fear of going to seek treatment, knowing that if it isn't COVID, then it could be all the money gone, or worse, being like greatly in debt. And so we have that problem. And I wanted to go into the Medicaid problem. So Medicaid program has been a lifeline for low-income Americans, pregnant people, the elderly, and people with disabilities. It's jointly funded by the states and the federal government. It's been operating for 54 years. More than half of the 391 Floridians in the Medicaid coverage gap are people of color. And that means that because we haven't expanded Medicaid, people are in a coverage gap where they are not accessing Medicaid because they make just slightly too much and they don't make enough to get subsidies from the exchange insurance. So we have a ton of people who are in this coverage gap that just can't have adequate health insurance. And that is a contributor to why we're seeing these kind of problems with COVID. And this is an ongoing problem even before COVID. So then through COVID, we also know that substance use and mental health needs, the need for mental health services is on the rise. But behavioral health is largely seen as a white issue. From 2013 to 2017, though, Black and Hispanic Floridians under age 64 died from drug overdoses at a rate more than 2 times greater than white Floridians. And even now, death by suicide is on the rise for young Black men, but mental health services and party among professionals is still largely targeted, party among professionals is still targeted largely for white affluent communities. And another area of disparity that existed before but still exists through COVID is the bad rates of maternal mortality for Black women, and that Black women aren't being the care that they need, aren't being given the care that they need as they go through labor. And earlier, one of the other panelists had spoke about the implicit bias related to pain of Black people, and so when Black women are explained to their doctors that they're experiencing pain, some doctors are not taking that seriously, and then that contributes to the bad rates of maternal mortality for Black women. And so we have a bunch of areas of concern, and COVID adds this confounding factor to each of these. So policies that have created this imbalance, right? The economic opportunity, the vibrancy of our neighborhoods, and access to education and income are conditions set by society, and the leaders who can best address the root causes of this imbalance are policymakers, because they set the policy that can contribute to these changes and the foundational environment that we have. So the built environment, for example, the design of roads, pedestrian routes, can thwart efforts to walk or bicycle to the store or work. And poor and minority neighborhoods are often food deserts with limited access to healthy foods, but numerous fast food outlets. Schools in low-income neighborhoods often serve inexpensive processed foods and rely on revenue from vending machine contracts that promote soft drink and high-calorie snacks. And Florida has been reluctant to expand Medicaid, and that has contributed to wider disparities in access to health care, especially with only 24% of Florida employees being full-time salaried employees. And that statistic has definitely changed since then. So the imbalance has been created because of decades and really centuries of policy that needs to be amended and reversed. And so legislation that can help. Black families typically have 10 cents for every dollar of wealth held by white families. This racial wealth gap has grown over time, and the Great Recession exacerbated it. Black families had lost a larger share of their wealth than white families. Given these lower levels of wealth, many Black families were not in the position to prepare for and respond to the recession. And now they're not having the opportunity to prepare for and respond to the pandemic, and they'll have a harder time recovering. And this recession that we're going through now is expected to be worse than 2008. And it will take many years, even with this idea of reopening the economy, it will take many years to recover from and recreate the jobs that we've lost. During an economic shock like this one, families need a stock of wealth to help them deal with the disruptions caused by the pandemic and give them breathing room if they lose their jobs or if they're furloughed. And for example, families who own their homes outright would not have to worry about paying a mortgage or rent if they lost their job as a result of the pandemic. And the first thing I want Congress to consider is no strings attached ongoing cash transfers that other countries have initiated. And I don't think that $1,800 is going to get people through 10 weeks. I don't think that that's a radical notion to feel like that's not enough money to keep people afloat, and they need to provide much more cash directly immediately. And so providing cash directly to individuals has been met with criticism, suspicion, and fear. The thinking goes that if people who need financial assistance are given money, you know, what are they going to do with it? They're not to be trusted because their financial position reflects a moral failing. But the reality is that people who don't have money, it's just a myth. They just don't have money. It's not that they don't understand how to save money and whatnot. And we need people to have a savings, a wealth in order to get through this. And at all times, really. And by providing cash, we alleviate the fears that people are facing as rent payments, feeding their children, or any other debt looms over their heads. Steps should be taken to rebuild an economically resilient society, and wealth gives people the resilience to weather a crisis without succumbing financially. And tax subsidies already exist to promote wealth accumulation, but nearly 80% of these tax subsidies for home mortgage deductions and property taxes go to the wealthiest 20% of income earners. So that right there is a statistic that really evidences the inequality that we have and that can be changed through policy. And to further help low wealth families recover from the pandemic, lawmakers could create a more equitable distribution of the existing tax subsidies. And yep, we're running out of time.
Yeah, thank you so
Go for
much,
it.
Jessica. We're running out of time. And I wanted to give our attendees just a few opportunities for us to answer questions. So we do have a couple of questions for the chat from the Q&A box that I'm just gonna go through really quickly. So if all of our panelists can unmute themselves so they can answer. So it takes so much work to put something like this together. You know, we have 2 physicians who are active in practice, so they had to take time out of their busy schedule. Leigh Ann is currently running 2 organizations who are doing amazing work in the equity and innovation space. And then of course, Representative Jones unfortunately could not attend due to a last-minute emergency meeting. And so I'm so thankful that Jessica stepped in. Thank you so much, Jessica, for providing and sharing your expertise with us.
I did my
so
best.
we're gonna go through these questions really quickly because I know I promised that we'll get off by 2:10. So let me make this quick. So the first question was Indigenous population. So we didn't have enough time to cover the data specifically around Indigenous communities. So we know that in certain communities where, in certain states, all of the deaths have come from the Indigenous population. So we do have to have a much larger conversation on how we're providing services and how we're making the connection. So here locally at United Way, one of the things that we're currently working on with Seminole Police Department is how to kind of help build that relationship. And so a couple of months ago, my colleague and I, Aisha, we actually visited the local tribe here. And so we're continuously working on what can we do as practitioners and individuals and organizations in the equity space to make sure that all voices are heard and making sure that we're providing access to services to all communities. The other question that we have is, I think Vanessa's, many minorities are essential workers and earn minimum or below minimum wage, or those who have their hours significantly reduced. How can we help them afford to purchase healthy food options and ways of cooking using what they have at home and the types of food that they can purchase? So I don't know if Dr. Fatteh or Dr. Haffizulla wants to answer that question.
Sure, I can start off. Can you hear me?
Yes.
Okay, great. So we have some great resources here in Broward, and I know that the Broward Regional Health Planning Council, they have access to several different resources in the community. We have 211 Broward also available, where there are some resources where you have complimentary services provided. There are some community gardens as well, where you have very, very low costs to some of the foods that are there. Those are some sustainable gardens that you can access through some of the grant projects that are ongoing as well. And some of I know that the University of Florida's food nutrition program, they have a SNAP program and they have an education process through it, but they sometimes can provide food and different resources to help in that arena. I would encourage you though to tap into also the Florida Department of Health, the Broward County Department of Health, because they also have some ongoing programs.
Okay, thank you so much. The last, another question that we have, and I think we're is, does this take into account mental health and the stigma within the Caribbean minority communities overall and seeking mental health treatment? In the age of COVID-19, social distancing, quarantine, and limited movement, this belief is still prevalent among many medical practitioners and other mental health workers. So I'm not really sure what the question is. Does this take into account mental health stigma and within the Caribbean community? So though we did not necessarily cover fully behavioral health, here at United Way, we do have a behavioral health arm. And so, yes, it's important for us to consider when we are creating materials, content, and when we are hiring clinicians to make sure that they're a good representative of our community. And then Aisha, our lead trainer, does an excellent job of providing community training to help build cultural competency and cultural humility. So if you are a person who maybe comes from a different community than the client you're serving, it's important for you to understand their value system and how your clinical approach may be most effective. Did any of the other panelists have any comments?
The only thing that I would add is for those that have capacity, we're seeing a significant uptick of resources being provided online, and a lot of things like from the cooking classes to info sessions about the various resources that are available for people, particularly essential workers or those that fall in the low to moderate income kind of bracket. And so I would just encourage people to continue to do what we're doing with the webinar, but also look at the various resources that are available online. I know every Thursday we have between 10 to 12 different workshops and things that are for people and designed to make it interactive so people can get their questions answered and can get direct relationships with the organizations that they need to help support them during this time.
So we have a lot more questions actually that came in through the Q&A box, but due to our limited time, what I will promise is that we will take your questions, and then hopefully next week we'll provide answers to your questions on the United Way website. So that is www.unitedwaybroward.org. And so we'll be able to answer your questions. Again, the PowerPoint will be emailed out next week, and it will have, if our panelists are okay, I will provide their contact information. They're doing amazing work in the equity space. So if you'd like to connect with them, we highly encourage that. And then if you, once we are no longer social distancing, I do encourage you to venture out and look at the Venture Cafe. They're doing some amazing work around innovation and technology. And I think as human service providers, it's important for us to look at how we could integrate that more in the work that we're doing. Thank you so much again for participating in our webinar. Again, we will have more opportunities to facilitate more webinars based on equity. I know we did not cover LGBTQ issues, and so we'll have a separate webinar to discuss specifically issues related to the LGBT community. And of course, we'll come back and talk about some of the work that we're doing with our Indigenous community. And so thank you again. I ask that you continue to look on our website for more information, and you all have a great evening. And I wanted to thank our panelists again. Jessica, thank you so much for stepping in for Representative Jones. I know he wanted to be here today. Dr. Fatteh, Dr. Haffizulla, thank you so much. And again, to our amazing team at United Way, on behalf of our CEO, Kathleen Cannon, and our Chief Community Impact Partner, thank you so much. And thank you to my amazing director, Janine, who gives me the space to really push things that I'm passionate about. You all have a great evening. Stay safe. Thank you.
Thank you.
Much. Bye-bye,
Thank you
everyone.
so much. Good night.